So my name is NiCassia Gabiola. I'm a speech language pathologist or speech therapist here at Arbor Health. This is going to be trouble. So as my title indicates, I do work on speech and language, but another part of my job is to work on swallowing. So I'm going to teach you guys a little bit about the swallow today. So I want you to picture this. So imagine you've planned a vacation to Cancun, Mexico. And it's rainy season here in Washington, so essentially it could be any time of the year. And you are so excited, you can feel the sunshine on your face just thinking about booking this trip. What other things do we think about when we're booking trips like this? We can't just simply lay by the beach. We have to take advantage of the Mexican treats that are at our disposal. Things like carne asada tacos, sorry, there's meat in there, with cilantro and fresh lime. That's often accompanied by some warm tortilla chips and made-to-order guacamole. And who could forget dessert? Some sizzling hot cinnamon sugar churros with dulce de leche and chocolate for dipping. And naturally, a cocktail to help you relax by the pool or the ocean. So eating and drinking not only nourishes our bodies, but it helps bring us together. Both new friends and old, it just helps us connect. But did you know that you could face some difficulties with your swallow? The pleasure of eating and the capacity of chewing and swallowing can change drastically or even lead to a complete inability. So dysphagia is a fancy term meaning difficulty or discomfort in swallowing as a symptom of disease. So this interrupts the process of cranial nerves communicating with muscles. And again, I want to emphasize that this is not something that can happen independently or on its own. It's something that occurs as a symptom of disease. So now's my time to check in with the audience. How are you guys feeling? So some of you might be feeling like, cool, NiCassia, thanks for that information, but this is not going to happen to me. I'm not worried about it. Some of you might be thinking that maybe you've had an experience like this before yourself or a loved one, and I've sparked your interest and you'd like to hear more. And some of you are straight up terrified. How could I even bring up the thought of someone taking away your churros during your Mexican vacation? So swallowing just happens automatically, right? We don't even have to think about it. We just maybe have an idea or two cross our minds about the caloric intake of the food. Maybe we think about the residue that it might leave behind in our teeth. Basically, we put the food item or drink item in our mouth and we chew it like we've been doing since we transitioned from breastfeeding to solids and liquids, and down the hatch it goes, right? So what maybe you didn't know is that the swallow is an extremely complex process. So it involves 6 different cranial nerves that's communicating with 50 different muscle groups. So it's quite complex. So when you have a problem with the swallow, the communication between these cranial nerves and muscles is interrupted, like I've mentioned before. And there's approximately 17 different components that has to occur in our swallow. And these 17 components are embedded into these 4 phases. So oral prep phase, oral phase. When I say oral, I just mean in the mouth. The pharyngeal phase or the throat phase of the swallow. And then the esophageal phase, which is the phase that initiates digestion. So on this slide, I want you to pay particular attention to the word preparatory or preparation. So that's exactly what's happening in this phase, is we're preparing the food to be swallowed. So there's some things that have to happen in order for us to prepare the food efficiently for swallowing. So we introduce the food or drink to our mouth. Our lips have to close tightly, so we have to create a really strong seal. Without that seal, we would get food and drink that would be spilling outside of our lips when we're trying to chew. We have to have really good cheek tension, so our muscles in our cheeks have to tense so that food and liquid doesn't spill between our cheeks and our gums and the pockets right there called the lateral sulci while we're chewing. we have to get this good circular mandibular range of motion when we're chewing. So without that, we wouldn't be able to chew the food efficiently, and we might try to swallow when there's whole pieces of food still in our mouth. And then we have to have really good lingual or tongue range of motion and strength in order to scrape the food off of our teeth and back onto our tongue. And then the soft palate helps to seal the food in our oral cavity so it doesn't spill backwards too early. And then we have the oral phase of the swallow. So this begins when the tongue starts to move posteriorly or backwards. So the tongue squeezes the food along the palate until it reaches the anterior fascial pillars. So I know all of you have done this before, but think about if you've been in the bathroom and you open your mouth and you look in the mirror, that hanging down thing in the back of your throat is called your uvula. So the tissue on either side of your uvula is the anterior fascial pillars. And right when the bolus, or the thing that you're eating or drinking, reaches that point, that's when the swallow reflex is triggered. This whole system for the oral phase takes about a second. The oral prep phase, or the preparation phase that I just talked about, it really depends on what you're chewing. So if you're chewing a piece of steak, for example, it's going to take much longer than if you're eating a bite of yogurt. And then we have the pharyngeal phase, or the throat phase of the swallow. So in this phase, your soft palate elevates to close off the nasal cavity because we don't want food and drink flowing upwards into our nose when we're trying to swallow. And then the pharyngeal muscles, or the throat muscles, squeeze the bolus through the upper part of the throat. And again, when I say the word bolus, I mean whatever it is that we're eating or drinking. And then airway protection begins. This is so much easier for me to explain airway protection with my hands, so I'm gonna do the best I can without them. So if you look over here, I'm just gonna point out, this is our trachea, which ends up in our lungs, and then this is our pharynx that goes into our esophagus. So our true vocal folds sit at the top of our trachea, and their job is to vibrate and give us sound when we're talking, but they also have a dual purpose. So they serve to tighten and protect the top of the airway when we're swallowing. So our airway protection works like a 3-layer protective mechanism. So we have those true vocal folds that sit at the top of the airway. Then we have the false folds, or the interventricular folds that fold over that. And then we have this leaf-like piece of cartilage in our throat that's called the epiglottis. And it tilts, it retroflexes backwards and meets with the arytenoid cartilages. So it sort of creates a slide so that what we're eating and drinking can flow nicely from our pharynx into our esophagus. So that system works pretty remarkably well if everything's working like it should be. And then at the top of the esophagus, we have what's called the upper esophageal sphincter, which is just a band of muscles that's typically left closed really tightly because we don't want acid from our stomach to come up into our throat. But when we swallow, that band of muscles relaxes and it allows food to flow from our pharynx into our esophagus. And then we have the esophageal phase of the swallow. This is, by the way, not within my purview. If I have a patient that has issues in the esophageal phase of the swallow, I would refer them to gastroenterology, and they would take it from there. So this is when the bolus passes through the upper esophageal sphincter, that band of muscles I was just talking about. And then esophageal peristalsis begins. So that's just a fancy way of saying these wave-like muscle contractions that pull the bolus into our stomach. And that phase takes about 5 to 6 seconds. The oral phase takes the pharyngeal phase takes no more than 1 second regardless of age. So this right here is a picture of a modified barium swallow study. I don't know if you guys have seen this before. This is the swallow in real time, so you can see that it happens quite quickly. This is one of the tests that speech-language pathologists can perform to identify the problem with the swallow. So it's our job within our purview to look at the swallow objectively. Let me back up a little bit. If we have a patient come in and have an evaluation, I can give them things to eat and drink. I can look at the muscles of their face, but I don't have x-ray vision. I can't see through their skin. I don't know what those muscles are doing. And so it is important for us to perform an exam like this one to identify the problem or the problems with the swallow so that we can generate a treatment plan for them. If it's something that's outside of my purview, like I just mentioned with GI, then I'll refer either back to their doctor or to ENT or otolaryngology or to the GI doctor. And then what are the signs of dysphagia? So what are some red flags that might be pointing to a problem with the swallow? So the first one here is probably something all of you are familiar with. So coughing or choking while eating or drinking is a major red flag. You probably should have your swallow checked out if this is happening every time you're eating or drinking. Persistent drooling is an indication that there's maybe weakness in some of the facial muscles. Watery eyes or runny nose while eating or drinking. I want to highlight while eating or drinking. If you have hay fever or a cold, that does not mean that you have a problem with your swallow. That's actually an indication of silent aspiration. This works when I don't want it to work, but then it doesn't work when I want it to. Reflux, so bringing food back up, sometimes through the nose. That can be an indication of a problem with your swallow. A sensation of food feeling stuck in your throat. We call that globus sensation. So a lot of patients will have this sensation often like hours after they've eaten. They feel like it's still stuck there. I've had one patient describe it as like a chicken bone. I feel like there's a chicken bone stuck in my throat and it's been there for days and I can't get it to go down. So that sensation is an indication that there may be a problem with your swallow. Being unable to chew food properly, and then a gurgly, wet-sounding voice. You guys have probably been around someone maybe when you're eating a meal and they're trying to talk while they have food in their mouth, or maybe right after they swallow, and they have to kind of clear their throat to clear that sensation. That's also an indication of a problem with the swallow. So what? Who cares? How does this affect us? So if we have a problem with the swallow and it goes undetected or untreated, it can lead to a whole gamut of problems. So number one, dehydration, malnutrition, the inability to maintain a healthy weight. Your risk of choking increases exponentially. And then this can actually lead to a really scary infection called aspiration pneumonia. So this is an infection or an inflammatory process of the lungs, which occurs when food or drink enters the trachea and then ends up in our lungs. So there is a course of treatment. Doctors may prescribe antibiotics to help with the aspiration pneumonia, but depending on the patient's condition, it can also lead to death. So it's not something to take lightly. Okay, so who is most at risk? So patients following a stroke, Parkinson's disease. Back to the stroke one, about 67% of patients following a stroke will have problems with their swallow. A lot of them will resolve pretty quickly, but some of them have effects that will last quite long and maybe even the rest of their life. Parkinson's disease, traumatic brain injury, polytrauma, tumor, especially if the tumor's in the brain, infection, cognitive decline or dementia, autoimmune diseases, MS, GERD, we just talked a little bit about that, COPD or any respiratory illness. This is because a lot of those patients will have difficulty coordinating their breath with their swallow. I put this one on the slide. It's actually not super common, but status post-heart surgery. The reason why I bring this up is because we have a really important nerve called the recurrent laryngeal nerve, and it wraps around our aorta. And if that somehow gets nicked during surgery, it can actually cause problems with the vocal folds closing, which in turn can cause problems with the swallow. And then ACDF stands for anterior cervical dissection and fusion. So this is a procedure, it's a spinal fusion procedure, but instead of going in through the back, they go in through the front. So they have to retract tissue of the pharynx and the esophagus or push it aside in order to get to the spine. And as you can imagine, that can often cause problems with muscle function. I have a patient right now that has had problems for 3 years with her swallow because of that. Okay, so in conclusion, awareness is the most important thing. So knowing, just being aware of what the symptoms are and how you can get treated can help us get the ball rolling toward identifying what the specific problem is and then coming up with a treatment plan. We have a team of fabulous providers here at Arbor Health that are very well educated about this concept. They can give you some education and make the appropriate referral. These are the 2 tests that I was kind of talking about that speech-language pathologists like myself can perform. The modified barium swallow study is like the study that you saw on the slide before, maybe 3 or 4 before, that lateral view of the swallow in radiology. So the patient's given barium, and it basically makes different structures in their mouth and throat show up so they can see where the problem is. We don't have this equipment here at Arbor Health, but there are hospitals nearby that do perform that. And then we have FEES, which stands for Flexible Endoscopic Evaluation of the Swallow. That's depicted in this picture here. That is some equipment that we invested in this year, so I can perform those here at the hospital. It basically consists of inserting a scope through the nose. It sounds scary, but it's really not that scary. There's a light source and a camera on the end, so I can visualize tissue abnormalities, and then I can watch where the food goes when the patient swallows. So while the tube is in there, they swallow food that's dyed green, and I can get a better idea of what's going on with their swallow. So once we get that objective information, we can decide, is this an issue with strength? Is it an issue with timing? Is it an issue with coordination? Maybe all 3 are affected. And then we can recommend some exercises that the patient can do. Swallow exercises are quite different than the exercises that you would do at the gym. We can do a form of electrical stimulation, so placing electrodes on the face or the throat to stimulate the muscles while the patient is participating in exercises. We might recommend a posture modification, so maybe they tuck their chin down or they move their head to one side, and that actually helps mitigate aspiration or penetration. We also might just change their texture, so what they're eating. Maybe they have a hard time with mixed consistencies, and so they can no longer have like cereal with milk in the interim while we're trying to work on the swallow, or maybe puree is best for them while we're trying to work on the swallow. Yeah, I realize this is an introduction to a completely new presentation than the conclusion to this one, but I appreciate you listening. Thank you.